Okay. First of all, my name is Shan and I'm from Nanjing Medical University. So my section will mainly focus on neurology. Now, for those who are in the first year, don't worry because I will be combining both neuroanatomy and neurology in this lecture. Okay, it's not just one topic. It's not just one subject. We are going to do both together. Okay, those who have done the previous lectures with me, you should know what I mean by this. So let me start. Okay. So till now, we have done several topics, including, let's say, we have done topics like seizures, coma, Parkinson's disease, then spinal anatomy and spinal diseases, everything we have done. Okay. Epilepsy, management of epilepsy, all of these we have done. So this is what I meant. I'm doing a combination of both anatomy and neurology because I'll be giving the anatomy part first. The relevant anatomy for each section, I will give that first. Then I will do the remaining part. Like I will tell you how to correlate that clinically. Okay. And the first thing is, please keep your cameras on and be interactive. Okay. When I ask questions, please answer. So just take a blank piece of paper because I'm going to go through some basic anatomy. And if you have not done this before, in the sense, if this is your first class, don't worry, this will keep coming up. Like for each lecture, I will be building up on this, okay? And there are times when I tell you, please don't draw it. Just don't draw it then because it will be drawn. I will most probably erase that and draw a better diagram later, okay? So first off, now, at the end, okay, just take a blank piece of paper and in the middle, somewhere in the middle of that paper, just draw this thing, okay? So first thing, at the end of the spinal cord is where we get the brainstem. So this is where the foramen magnum is. I hope you guys can see it. This is where the foramen magnum is. And from the point the foramen magnum begins, we start our brainstem, okay? This is called the medulla. This is called the pons. And this is called the midbrain. It is basically, the midbrain is basically a pillar for the cerebrum, okay? So the first thing is, I will just talk about some structures of the midbrain, which is relevant for today's class. Later on, I will do a proper lecture on the midbrain, sorry, on the brainstem. But for today, I will just talk about the relevant structures. There are some outgrowths, like areas coming out from the pons. This is the pons area. And this area, the way I remember this is, okay, this is an obvious thing. It's called OPPO, OPPO, olives, pyramid, olive. Okay, that's the name of the structure. Okay, it is called OPPO. And over here, we have the cerebellum. Cerebellum is posteriorly located. It is behind. Okay. Now, there are three connections from the pons, from the medulla, the pons, and the midbrain to the cerebellum. These are called peduncles or peduncle or foot processes. It's basically the foot that touches the cerebellum. Okay. So you can label this simply as, this is the superior peduncle, superior cerebellar peduncle. You can label it on one side, middle cerebellar peduncle, and inferior cerebellar peduncle. Okay. Then there are sulci, which separates these three into three areas. And remember this is the midbrain. I have taken a section of this whole thing. This is called the cerebral peduncle. So what I'm doing right now is basic anatomy, which you will need. Okay. Now, let me talk about the ventricles, the CSF flow. So in the spinal cord, we have something called the central canal, where you get CSF flowing. Once it comes above the foramen magnum, think of, okay, let me just draw a diagram of the spinal cord. So this is the gray matter region right now, which I'm drawing. And in the middle, we have over here in the middle, we have the central canal, which carries the CSF upwards like this. Okay, I hope you guys understand that. And this fact is going to be very important later on. Okay, this area, the anterior area. Okay, I have told this several times before. I have drawn this in several diagrams for the people who have already attended. That is the motor area. So if there are any high school students, I know you guys have learned something called the reflex pathway. Right? This is just for you to understand this concept. I know you have drawn the reflex pathway. Okay. So what I drew is the dorsal root ganglion. The sensory nerve comes from here and is present in this area. Then there is the, intermediate neuron, which gives rise to a neuron. So give me a second. This is the motor neuron that leads to a muscle. Okay, sensory neuron, intermediate neuron, motor neuron. This is high school stuff. And what you need to know is sensory area is posterior. Okay, sensory area is posterior and motor area is in front. This something called the basal plate and the ala plate. Okay, that is embryology. I won't go into that. So the other thing is, I will talk about this is just a reminder, the spinal arteries. You have three main arteries. Here's the posterior spinal artery. And you have, okay, two of these. You have one anterior spinal artery. Okay, I hope this wasn't hard. This is the very basics. Now, we come back to this. Oh yeah, I forgot. So what happens once the spinal cord enters the foramen magnum and becomes the medulla? You basically take your hand and you stretch out the central canal. You basically stretch it out like this. Okay, that is what happens here. In this region, okay, this is the most posterior aspect of the spinal cord. Okay, what do I mean by that? If you cut from front to back of the spinal cord, the central canal is present in the back, more towards the back. Okay, so in this area, you get this enlargement. Can someone name this? What is this enlarged area called? Can someone name this? What is this area called? Guys, unmute and speak. You can try. It's not hard. This is called the fourth ventricle. Okay. Yes. Telini, yes. This is called the fourth ventricle. And once you come to the midbrain area, it changes to a, it is called the cerebral aqueduct of Sylvius. You just remember it as cerebral aqueduct. If you want, you can write this Sylvius. Okay, this is called the cerebral aqueduct of Sylvius. Just remember it as the cerebral aqueduct. Now, what I'm going to do is, I need you to understand this. This is called the cerebral peduncle for a reason. This is the point in which the cerebrum will connect. And the cerebrum, don't draw this. Think of the cerebrum like this. It has a base. It has a base, don't draw this. And it connects like this. Okay. Now this base area is called the diencephalon. Okay. I will draw this again. Okay, now what does this mean? From here, we move forward. We move forward like this. This is called the third ventricle. Okay. From this area, it moves forward like this, and it is called the third ventricle. And over here, there are two very important structures. Okay, if I'm to draw it in a 3D aspect, I have to draw it like this. So, okay, but just for the lecture, you guys can draw it like this because it will help you understand what the thalamus looks like. This is called the thalamus. Okay, you can draw, if you can draw that Y shape inside that, it's fine. If not, just draw this on top of that like this. Okay, so this is called the thalamus. Now, there are two structures which I need you to know. Lateral to the thalamus, there is something called the medial. So this is going to be the lateral. Okay, label it from one side. Draw it on both, label it from one side. Lateral and medial geniculate bodies. Geniculate bodies. Okay, lateral and medial geniculate bodies. From the, okay, for the medial geniculate body, we have our hearing. It's the hearing that comes and connects to the medial geniculate body. But our concern here, yeah, when it comes to the anatomy, is the lateral geniculate body, because we have the optic tract coming like this, both sides. We have the optic tract coming like this. Here is the optic chiasma. This area is called the optic chiasma, C-H-I-A-S-M-A. We have that coming. And this is called the optic nerve, what I just drew, and we have the eyeballs. Okay. So the structures I'm drawing right now is the diencephalon. Okay, the thalamus, then the geniculate bodies, and now I will draw the hypothalamus. So the hypothalamus is basically the space in between the third ventricle. Let me extend the third ventricle forward. So the space between the third ventricle is called the hypothalamus. This area is the hypothalamus. Okay. And like two testes descending from the hypothalamus, let me draw it like this. So from the hypothalamus, you have a structure. Can someone name that structure? Like two testes. Can someone name the structure?
Pituitary.
Yes. Pituitary gland. Okay. This is the pituitary. And like two breasts, you have, so it's underneath. Okay. Understand the fact that it is underneath. When you look from the bottom, you will see the testes hanging and the two breasts hanging like this. This is called the mammillary bodies. And I hope you guys remember where I taught you this. This is in relation to the Pappes circuit. I did this in relation to the Pappes circuit. Where is it? Yeah. Okay, I did that in relation to the Pappes circuit, which is involved in a disease called Wernicke's-Korsakoff syndrome. Okay. So this is based. Okay, let me just give you a brief idea of what the mammillary body does. Mammillary body is involved in short-term memory. There's a circuit called the Pappes circuit, and if this is damaged, so there's the hippocampus, all the structures. If that is damaged, it will lead to a condition called Wernicke's syndrome. Okay. That is a past lecture, so I cannot go into detail here because it will take too long. But right now our focus is on anatomy. Now I hope you guys understand this. It is not hard. Don't yeah. You guys, it's best if you don't draw it, just understand it, because we will learn this later on in future lectures. So basically, here is the this is going to be the second or the lateral ventricles. They come like this. Don't draw this. Just try to look at this and understand. So you have the lateral ventricles that originate from the third ventricle. It comes up, divides to the sides and goes back and front. Okay. This is called the lateral ventricles. And now I need to talk about today's lecture. For that, again, don't draw this. Okay. Actually, you guys can draw it. It's fine, because I don't think I'll come back to that again today. You need to know this. Oh yeah, I forgot to include a few more structures that we discussed. There is a nucleus, a special nucleus, which is related to managing your hunger, your eating. It is called the habenular nucleus. It is related to your eating behavior. Habenular nucleus. It is related to your eating behavior. And there is one structure which originates from this point of the ventricle going like this. It is called the pineal gland. Okay, pineal gland. And just for the sake of completion, this is, you need this for basically basal ganglia and Parkinson's disease. There is, okay, I used a bad color, but there's something called the subthalamus. So sub means below. It is just below the thalamus. Okay, I hope you guys understand this. This is the basic anatomy that we have already discussed. Now, let me talk about the circle of Willis. Look, if I can, I will put it like, okay. The circle of Willis is located like this. It is below the pituitary. So basically, the circle of Willis is located like this. Okay. This is going to be our main discussion today, the circle of Willis. Don't worry, we will draw diagrams to properly understand this. But for now, I need you to understand how the circle Willis is located. It is below the pituitary. It's like with the pituitary, basically. And whenever there's an arterial drainage, there has to be a venous drainage. The venous drainage is located lateral to the pituitary, like this. Don't go to draw this if it is too cluttered. Okay, we will discuss these over time. I just want to talk about the locations of these, of what we are going to learn today. This is called the cavernous sinus. This is the venous drainage. Okay, I hope you guys understand this. There's one more thing I want to add, that is the cranial nerves origin points. So let's draw this diagram again. This time we will talk about just the cranial nerve origin points. Okay. Do you guys understand this? If you have any questions, you can ask. Okay. Give me a second. If you don't have any questions, let's continue. Don't be shy to ask questions, because that is how you learn and that is how you understand. Okay. If you have any question, you can ask. So this is the medulla. This is the foramen magnum, the pons. Then we have the midbrain. We have the cerebellum, cerebellar peduncles, superior, medial, and inferior. Okay. And over here we have the thalamus. Then, okay, let me just review this. Don't draw this, because I need, okay, don't do anything to this area. You guys can draw the rest, but just don't do anything to that area. I'm not going to draw the enlargement. Okay, here's the enlargement. It goes from the geniculate body, the lateral geniculate body, we have the optic tract. Optic chiasma and optic nerve. Optic chiasma, it's where the nerves coming from the eye, the optic nerve bifurcates. That means it crosses. Okay. Pre-departure students or anyone who hasn't learned anatomy yet, don't worry. We will discuss these later. Okay. And then we have the hypothalamus here. Hypothalamus here. It fills this whole area basically between the optic tract and the ventricle. Okay, and here's the pituitary, mammillary bodies, and that is just a recap, okay, of the main structures. Habenular nucleus, pineal gland. Can someone tell me what is released from the pineal gland? Can someone tell me what is released from the pineal gland?
Melatonin.
Melatonin. Okay. It releases melatonin. It regulates your sleep-wake cycles, and yeah, actually brings about changes at the correct age. Okay. Habenular commissure. There's a connection between the two habenular nuclei. Basically, white fibers have fancy words. It is one of them is called commissure. I discussed these for the previous lectures. I'm thinking about either doing the classes again, or we are discussing what we're going to do for the previous lectures. So don't worry too much if you missed anything. Don't worry. This is the habenular nucleus. So this is the habenular commissure. Can someone tell me what is a nucleus? Can someone tell me what is a nucleus? We learn about nucleus in the central nervous system and everything. Can someone tell me what it is?
Group of neurons in the central nervous system.
There's one word you missed. It is the cell bodies of neurons. Okay, cell bodies of neurons are found here in the nuclei. Because the cell bodies are accumulated like this. This is the definition of a nucleus: a collection of neuronal cell bodies. Okay. Then there's, okay, this connection actually goes to the cortex. Something happened. Give me a second. My pen stopped responding. Guys, give me a second. Okay. So basically, a nucleus is a collection of neuronal cell bodies. Now, a nucleus is made up of two parts: the axons, or the tracts of the nucleus, and the cell body. Two major parts. Okay. I hope you guys have learned the structure of a neuron. I'm going to consider the dendrites and the axons as the tract. Okay. The dendrites and the axons as the tract. This is the nucleus. These are the tracts. Can someone tell me why these are called, why is there something called the gray matter and why is there something called the white matter? What makes white matter white? I gave you a hint already. What is this that I just read?
Shwan, myelin sheath, yeah.
Yes, myelin is what makes white matter white. Okay, just remember that. So this is a habenular commissure that is going to contain, there is actually an interconnection between the left and the right side. There are connections to the cerebral cortex and actually from the bottom. Okay, so basically there is a connection between the two nuclei, and because it is in myelinated tracts, you get it as white matter, and a fancy word for white matter is commissure. Okay, we learn different words. Okay, I hope you guys understand that. Another word is column, dorsal column. Okay, so guys, please turn your cameras on. It actually helps me a lot, shows me how much you understand. I hope you guys understand this. It took a long time, but this is important. Now, let me talk about the cranial nerves. Okay, cranial nerve 1 and 2. This is the cranial nerve 2. Okay, this is where the cranial nerve 2 goes. Cranial nerve 1, it goes even above that and goes to the olfactory system. This is cranial nerve 1. Cranial nerve 1. There are 12 cranial nerves, and cranial nerve 1 goes like this. Cranial nerve 2 goes like this. This is called the olfactory nerve. This is called the optic nerve. So try to understand this 3D diagram. Cranial nerve 1 is above. It goes to the crista galli and comes out through the cribriform foramen of your nose. This is the one of the first topics you do when you study anatomy. Okay, let me just quickly show you what it is. So here's where you have your eyes. What I'm drawing is a picture of the base of the skull. This is called the sella trushica. This region is called the sella. Okay, don't label it there. Just label it somewhere, let's say here, sella trushica. Okay, and this is where the pituitary actually falls into. Okay, so on either side of the sella trushica, you have the cavernous sinus. Okay, draw this here, but basically you'll have to draw this again in the venous supply of the brain. Okay, this is where you have the cavernous sinus, and for the anatomy of people who will learn anatomy, this is called the superior orbital fissure. Okay, we will discuss that today. We will discuss about this. Here's the sphenoid bone, frontal and the occipital bone. Sphenoid. Okay, this is called these are the two wings of the sphenoid bone. Okay, this is the temporal bone outside. Frontal bone, actually this is the ethmoid. We have the occipital bone here. We're not going to go into that much detail here, but basically this is a recap of anatomy you have learned in the first year, which is relevant to us. Here's the crista galli, and this is this structure here. This is called the crista galli, and these small holes that originate from that is called the cribriform foramen. So the cranial nerve 1 comes out of those in the nose. Okay, I'm going to show you guys a diagram. I will explain that later. Let me just tell you about the cavernous sinus. It is 2 centimeters long and 1 centimeter wide. Okay, I hope you guys understand this. That is about cranial nerve 1, cranial nerve 2. Then we'll talk about cranial nerve 3. It comes from here. Okay, it originates from here. Can someone name the cranial nerve 3? What is the cranial nerve? Yes. Okay. Then cranial nerve 4 is the only nerve that comes from behind and comes forward. Cranial nerve 4 comes from behind. Okay. Cranial nerve 5. Cranial nerve 5 is a nerve that has 3 roots. It has 3 nuclei and comes out from the pons. Okay. Then 6, 7, 8. 6, 7, 8 come out like this. Okay. 6, 7, 8. I just need you to get a basic idea of what's happening and where stuff is. And OPPO, OP 9, 10, 11 comes out from the lateral side. 9, 10, 11 comes out from the lateral side, while cranial nerve 12 comes from the pyramid. Okay, remember you have to draw it on both sides, but for the sake of not messing up the whole diagram, I just leave it on one side for some nerves. Okay, we didn't do the lesson on cranial nerves. That will be next or the one after that. Now, we discussed a lot of the basic anatomy. Let's go into the arterial supply of the brain. Okay. The first question is, I have told this several times, where is the circle of Willis? Where is the circle of Willis located? Can someone tell me?
Around the pituitary.
Yeah, in which region? Is it under the skull, in the meninges, or in the brain parenchyma? Is it inside the brain? So I would say most of you don't realize this, but the arterial supply of the brain is located floating around the subarachnoid space. Okay. The arterial supply of the brain, that is the circle of Willis, floats in the subarachnoid space. It forms branches which pierces through the brain parenchyma. Okay, so let's get into this. First, I'll talk about the origin of the arterial supplies. The first is the heart. This is the heart. Okay. The first branch of the aorta is called, what is it called? Okay, not the coronary arteries. I'm talking about the carotid arteries. Okay. So the first branch is the coronary arteries, but then once you come to the trunk, it forms something called the brachiocephalic trunk. This is called the brachiocephalic trunk. The next one is the cerebral artery, and finally you have the subclavian artery. Okay, this is how the aorta divides. I'm talking. Okay, now we have something called the coronary sinus. This is called the coronary sinus. That is where we have several pressure receptors, which is related to maintaining blood pressure, and we have two branches from there: the internal carotid artery and the external carotid artery. Okay, the internal carotid artery goes to the brain. It goes through the foramen it goes through a foramen. I will come to that. But basically, it will go to the brain, while the external carotid artery supplies the face. Okay, internal carotid artery supplies the face. Then we have the subclavian arteries. Subclavian arteries gives rise to, its first branch is called the vertebral artery. Okay, the vertebral artery, from its name you should realize it is posterior. Okay, it is located posteriorly. These are the two vertebral arteries. It forms something called the basilar artery. Okay, vertebral artery, and it forms something called the basilar arteries. Okay, this enters the foramen magnum. The vertebral arteries are what enters the foramen magnum. Okay, now let me talk about its root. So basically what I'm drawing now, this what I just drew is called the foramen magnum. Okay, comes like this. Okay, actually, so here is your frontal, this is your face. Okay, I need to draw one more layer. Like this. Now the internal carotid artery comes like this. So the internal carotid artery comes like this, and it pierces through this area moves laterally. Remember that it moves laterally and enters into the brain. Let me use red for the internal carotid artery. So it pierces through and enters the brain. Wait. Don't draw it so close to the edge of this because it becomes difficult afterwards. So the internal carotid artery comes like this, pierces the skull, moves laterally, it moves to the side, and then ascends through a foramen which looks like this. Like someone has taken a bite out of this. It is called the foramen lacerum, Lacerum. Okay, it is called the foramen lacerum. And I made a mistake. I always interchange the two words. This is called the carotid sinus. Sorry, did I make the mistake again? Yeah, it's the carotid sinus. I keep calling it coronary sinus. I sometimes mistake the two. Now, here is where you have the cavernous sinus. Okay, what I need you to know is this will penetrate through the cavernous sinus and enter. It will leave. It will penetrate the cavernous sinus and it will enter the subarachnoid space. Enters subarachnoid space. Okay, it will enter the subarachnoid space. And what do we have here? Between over here, we will have the pituitary on the side. And it comes here and stops. Okay, let me go a bit higher to the point here. But it is basically between the pituitary, okay? It is. Now, from there, it divides into two branches. The anterior carotid artery and a branch which goes laterally, which is called the middle carotid artery. Middle carotid artery and anterior carotid artery. So this is the internal carotid artery, which divides into two branches like this. Okay, I hope you guys understand. From the other side also, we have the same structure. Here's the anterior carotid artery, then the middle carotid artery, which originates from the internal carotid artery. Okay, I hope you guys understand this 3D image. Then we'll talk about the one coming from the vertebral arteries. Okay, guys. So I make this mistake where I mix up carotid and cerebral arteries. Okay, sorry, it's those here. This thing I have. This is called the middle cerebral artery. Okay, middle cerebral artery because it's in the cerebrum. Sorry. Okay, anterior cerebral artery. This is the internal carotid artery. Sorry, I keep mixing those names up. Sorry for that. We'll talk about the posterior carotid arteries. Okay, so we have the vertebral arteries, which enter through the foramen magnum and become the basilar artery. Comes all the way up past it comes to the end of the brainstem, and above it divides into the posterior cerebral artery. Divides into posterior cerebral artery like this. Okay. It forms the posterior cerebral artery, PCA. Now, there has to be an interconnection between the posterior cerebral artery system and the anterior cerebral artery system. This is called posterior communicating artery. Okay, this is called the posterior communicating artery. Posterior communicating artery. Okay, and there has to be an anterior connection between the two ACA, anterior cerebral arteries. It is called the anterior communicating artery. Anterior communicating arteries. These are, compared to the other arteries, these are smaller. Okay. Now, I hope you guys understood this. Let's draw the structure again. This time, you guys have to tell me the names. What are these two arteries which I drew? I'm talking about the posterior circulation. What are these two arteries?
Vertebral.
Yes,
Basilar.
vertebral, basilar. And we have the posterior cerebral. Yes, thank you. Now, what did I just draw? What was that artery which I just drew? This is the internal carotid artery. What is this? The middle cerebral arteries, and these are the anterior cerebral arteries. Okay. Then you draw the communication between these. Okay, let me use a different color. Okay. I hope you guys understand these. Let me label it: anterior cerebral arteries, ACA, middle cerebral arteries, MCA, and this is the posterior cerebral arteries, the PCA, and this is the basilar artery, and these are the vertebral arteries. Okay, I will spend around an hour just on the anatomy. Okay, now what I need you to know is, over here is where you get the cranial nerve 3. Cranial nerve 3 originating. What does that mean? So basically, okay, where is that? This starts going like this. We will draw a diagram. I just want you to we will draw a diagram of the brainstem circulation. I just want to give you an introduction. So this is where it is, and right over here is where the cranial nerve 3 will start. Okay, so if there is any stroke or any damage to this area, that means the cranial nerve 3, which is involved in the movement of the eye, is going to be affected. Just don't worry, we will discuss these. Okay, just for now, right? Cranial nerve 3 originates there. Okay, it could there could be an aneurysm. Something can cause damage to the cranial nerve 3. Now, I need you to remember this rule. Okay, wherever the arteries go, it is going to give small supplies. So the basilar artery will give rise to the cerebellar arteries. Cerebellar arteries, the pontine arteries, and basically it will supply the whole brainstem. We are going to draw a diagram, so don't worry. It is going wherever these arteries go, it will supply the brainstem or wherever it is. Okay. Now, guys, look at the screen. Okay, I'm going to stop sharing. And actually, bad idea. I might not reconnect to the screen, but look at my image. Give me a second. Give me a second. So look at this. Look at my hand. So let me show it from the side. We are going to learn how the arteries come. Okay. This area is where you have the circle of Willis, this area in the middle, literally in the middle. Okay, between my fingers, 2 thumbs. From there, you have the anterior cerebral arteries that will come and supply. It will come and supply from this area, the anterior cerebral artery. Okay, let me talk about the middle cerebral artery. So think of it as this area, which, okay, look at my hand. Over here is where you have the circle of Willis. From here, you have the middle cerebral arteries which go this way. Okay, it goes this way like this and comes out from the other side and supplies this aspect. Okay, the anterior cerebral artery comes and supplies this aspect. Wait, I think it's better if I draw it in a diagram. Okay, so I will come back to that. Let's go to this. This is an MRI. This is called a angiogram of the brain. Okay, you can clearly see the circle of Willis, and if you have gone to hospitals and you have seen patients, you should have seen the structure in an MRI. Very common structure. This is the anterior cerebral artery. Okay, this is the middle cerebral artery. This is the posterior cerebral arteries. Okay, and this is the basilar arteries, and these are the vertebral arteries. I hope you guys understand this. This is the anterior communicating artery, posterior communicating arteries. Okay, basically it forms a circle like this. This is called the circle of Willis. What we just discussed, taking a lot of time, is called the circle of Willis. Okay. Now, let's talk about the brainstem. Is it too much? Is it too much information at once, or is it? Do you guys understand what is taught? So now, if we will talk about the brainstem and the arterial supply. Okay. So what I'm drawing right now is basically I'm going to draw the brainstem and show you the arterial supply. If you are using this note, I need space for one more diagram. Okay. So, okay, don't draw that. It's just waste of space. Now, the vertebral arteries are going to come up all the way to the medulla. It will come up all the way to the medulla. There, it forms the basilar artery, which goes all the way up. And in this area, where I told you the cranial nerve 3 is, will divide to form the posterior cerebral arteries. Okay. I hope you guys understand this. Now, I need to draw one structure which is going to annoy the hell out of you guys, because this is what we need for stroke discussion. The cerebellum. Okay. Okay. So guys, this is a free program. So if you are shy, don't worry. You can send me a message in the group asking your questions. Don't lose this opportunity, because you will not learn this for free anywhere else. Okay. So vertebral artery, basilar artery, posterior cerebral arteries, and these are the pontine arteries. Pontine, P-O-N-T-I-N-E, that supplies the pons. Okay. Now we are going to talk about the other major branches from this. First, we have the labyrinthine arteries. Okay. It originates from the pons. Remember, cranial nerves 7 and 8, 7, 8, 6, 7, 8. So this artery goes with cranial nerves 7 and 8 to the ear. Okay. So, can someone tell me what is cranial nerve 7?
Facial nerve.
Yes. What is cranial nerve 8?
Vestibular cochlear.
Yes. Okay. The way I remember cranial nerve 8 is there's an 8. Just draw. Okay. Ear to ear. It follows the cranial nerve 7 and 8. Okay. Remember this. Never write cranial nerves in Roman numeral. In this Arabic numerals. It has to be in Roman numerals. Okay. So you should write it as this. But for the sake of the new students who haven't studied anatomy, I'm giving it like this. Okay. Okay. So when it comes to studying the cranial nerves, there are mnemonics. Problem is, I don't know the mnemonics. I just know the cranial nerves from the way it starts. Okay. Like I know the 12 names, but not as a mnemonic. I will send you a mnemonic for you to learn that. Okay. This is a question I got. So next one is, let me tell you this. This is going to be the most important artery that we will talk about from this area. It is called the pica, posterior inferior cerebellar artery. The most important artery which we will talk about. Okay, it's called the pica. It actually, I made a small error here. It originates from the vertebral artery. It originates from the vertebral artery. Actually, it originates from behind. Like from the posterior of that vertebral artery, it goes down directly. It goes down, and remember, it's supplying the lower part of the medulla oblongata. That means I told you, if an artery goes somewhere, if you see it in the diagram, it supplies that area. Okay. Remember this. This is called the pica, P-I-C-A. And we have one which is originating anteriorly. Let me draw it anteriorly. This is called the AICA, anterior inferior cerebellar artery. Look at this. This is the base of the cerebellum. If you are to take a picture of the cerebellum, I don't have any pictures. It is going to wait. I should. No, sorry, I don't have any pictures for that. But basically, it supplies the base of the cerebellum. Okay, cerebellum. It supplies the base area. Okay, one is anteriorly, one is going to be posteriorly. Okay. Don't worry, these are just two names. Anterior inferior cerebellar artery. Okay, guys, if you have any questions to this point, please ask me, because if we are to continue from this point onwards and you don't understand a part, it will become difficult. Okay, remember, when you draw this diagram, the areas which you see the blood vessels coming out from, it will supply all those areas. Okay, so the pica will supply the bottom part of the medulla oblongata and the cerebellum. Okay, I hope you guys understand that small arteries will come out to supply all these areas. Okay, the brain is a very highly vascular structure. Guys, I'll give you a minute, go through what you learned right now and ask me any questions. Go through this. If you have any questions, you can ask. If not, I'm gonna continue. Okay, so do you have any questions? If not, I will talk about the final artery for the cerebellum. That is the anterior cerebellar artery, which comes from the midbrain area. From the midbrain area, it comes like this. Okay, it's called the superior cerebellar artery. Remember superior colliculus, sorry, superior peduncles? That's the area it comes on top of that. Okay, I hope you guys understand this. We will need this when we come to stroke discussion. Okay, if you have any questions, you may ask, because I'm about to draw the final diagram about the distribution. Okay, now do you guys understand this? Okay, thank you for the mnemonic. I will send it to you guys. So let me talk about the whole thing for a bit. What I'm drawing right now is the supply. Okay, how the supply is. Now we are going to cut from the middle. We're going to cut the brain from the middle. Okay, think of it like this, and you cut it from the middle. When you cut it from the middle, you will see this white matter called the corpus callosum. White matter area called the corpus callosum. Can anyone tell me what is the importance of the corpus callosum? This is actually very interesting, because this is in relation to why men have a bigger brain size compared to women. Don't worry, it's nothing that it's not anything that says that women have a smaller mental capacity. It is just related to the size of the brain. Okay, this is the reason why men have a bigger brain size compared to women.
Doesn't it just like join the two hemispheres?
Yes, exactly. Okay, now what I just said, the statement I just made, the reason why men's brain is bigger is they have a bigger size, but less fibers go through the corpus callosum. Okay, I hope you guys know your left side of the brain is for critical thinking, your logic, everything. Right side of the brain is related to your creativity. In women, they have more fibers going through the corpus callosum. Corpus callosum is basically white matter. It is the white matter that is basically the axons that connect from the left and the right side of the brain. Men have lesser, it's a less thick corpus callosum compared to the women's. Okay, that is actually the reason why women don't need a bigger brain, because they have a thick corpus callosum that carries. It's basically saying women are able to combine creative thinking and logical thinking better than men. Okay. Now, what I'm going to draw now is, here is the circle of Willis. Okay. Here is the circle of Willis. And remember, it's a cut section. I cut half of the brain. And I'm drawing this like this. Okay. From this is how the anterior ACA travels. Okay. This is how the anterior cerebral artery travels. It is going to supply the top aspect of the brain. It is going to supply the top aspects of the brain. I hope you guys understand this diagram. It's not hard. Okay. This is how the anterior cerebral artery travels. The middle cerebral artery travels to the side. Okay. Since we have cut one side, I can't show you here, but basically it comes out like this. It goes and supplies. So I can't show it in this diagram. The lateral aspect. So anterior aspect is from the ACA, the lateral aspect is from the MCA, and the posterior aspect is from the PCA. Okay, comes like this. So, okay, comes like this, supplies these areas, and comes out like this. Okay, I hope you guys understand this. Now let me show you this. So the structure we are concerned is over here, the circle of Willis. The ACA comes like this and supplies over the hand. The MCA, look at this, it goes through the brain and comes out from the other side and supplies the lateral aspect. Okay, and the PCA will supply the rear. I hope you guys understand that. Okay, and for the sake of studies, okay, just write this. Remember, it pierces through the brain, such as basal ganglia, internal capsule. Why is this important? Because in a stroke, you need to be able to tell which artery was supplied based on the symptoms the person has. Okay. Now the venous supply of the brain, I already talked about the cavernous sinus. Okay. But especially for the people who will do anatomy, I'm about to add two things. First thing, about the location of the venous sinuses. Okay. Now, the location of the venous sinus, venous structures is, now I'm drawing the skull of the head, a skull of a person. Okay, this is the skull of a person. Right below that, in a very loving relationship, you have the dura mater first layer. What I drew is the skull. What is in blue is the skull. What is in orange is the dura that sticks to bone, to skull, is called the endosteal layer. Okay, this is called the endosteal layer. This is very important. Okay, anterior. So for this question, the person who sent me a message, we will come to that. I will explain that fully. Just for now, trust me on this. Okay, basal ganglia, internal capsule. So the dura that sticks to the skull is called the endosteal layer. Then we have the dura, that is the next layer, that sticks with the meninges, the arachnoid layer. This is called the meningeal layer. Okay, it's still the dura, but it is called the meningeal layer, and it forms the two cavernous sinuses like this. Okay, it forms the two cavernous sinuses like this. So we have this is the cranium. Okay, what I just drew is the cranium. Remember, the endosteal layer loves the skull and sticks with it. This is the meningeal layer. Dura mater. And these areas are where blood collects. This is the cavernous sinus which I drew. These are areas in which blood collects, and they all drain through. Can someone tell me what is the draining vein of the brain, of this brain? Can someone tell me the draining vein? It starts with the I, next letter is J, and the final letter is V. It's the internal jugular vein. Okay. The internal jugular vein is going to take out the blood. And now I will just show you a diagram of the cavernous sinus. Guys, I think I drew a diagram somewhere. Guys, later on, just draw this diagram. Okay. Later on, just draw this diagram in this space. For now, I will just talk about the cavernous sinus. Because you will get this for anatomy, you need to know the structures that go through the cavernous sinus. Okay. Remember here, okay, don't draw it this big. Here's the pituitary. Can someone tell me which is the lateral aspect and which is the medial aspect? Is this the lateral aspect or is this the lateral aspect? Is A or B? A or B? Is A the lateral aspect or not? Which is the lateral aspect? This is
A.
It is A, okay? Because the pituitary is in the middle. Here's the lateral aspect. Okay. On the lateral wall, we have three cranial nerves which travel like this. Cranial nerve 3, cranial nerve, okay, wrong color. Cranial nerve 3, cranial nerve 4. Guys, the reason I'm taking this long to do the anatomy is because we need this when it comes to a stroke discussion. This is V1, V2. What do these V1 and V2 mean? What are these branches of?
Trigeminal.
Yes, the ophthalmic and the maxillary branches of the trigeminal nerve goes through the lateral wall of the cavernous sinus. Okay, so in this diagram which I drew here, these will come from the brainstem and go like this, and except for V2, except for the maxillary nerve, everything else will go through the superior orbital fissure. There's one more nerve, there's cranial nerve 6, but it is inside. Okay, cranial nerve 6 is the only nerve which is inside. Okay, remember that. These will go along the lateral wall. It is in the lateral wall of the cavernous sinus through the superior orbital fissure and supply the eye. These are nerves related to the eye. Okay, there's another structure which goes superior and medial in the superior orbital fissure, that is called the optic canal. Okay, that is the structure in this structure. Okay, it goes here. I told that for the sake of completion. Now we are talking about the internal carotid artery. So I will not draw the internal carotid artery here, but basically the internal carotid artery will pierce through the cavernous sinus and go like this. It goes forward. It's a box-like structure. It's a rectangle. It goes forward and goes up into the subarachnoid space. Subarachnoid space. Okay. And while it goes up, okay, let me draw it here also. So I need you guys to know there's a very special structure. The sympathetic nervous system travels in tandem, that is, travels with the internal carotid artery. Wherever that goes, the internal carotid artery goes. Okay, this is the sympathetic nervous system. Can someone tell me what is the function of the sympathetic nervous system?
Constricting.
Basically fight or flight response. Okay, you see a lion, you get scared. Yeah, you get scared and you need to dilate your pupils. Here you have a supply to cranial nerve 3. Okay, and you also have a supply to V1. Okay, I hope you guys know cranial. Okay, if you haven't learned this, we will do this. Cranial nerve 3 supplies all the eye muscles except for 2. What are the 2 muscles it doesn't supply? Cranial nerve 3. Any muscle related to the eye, including the ciliary body, which constricts or dilates the pupil, is supplied by the cranial nerve 3, except 2 muscles. It's a chemical equation. This
Left
lateral rectus and
the superior
oblique. Okay,
yeah.
Remember this mnemonic: LR6 SO4 R3. R here means rest. Okay, LR6 SO4 R3. Okay, do you guys understand this? If so, we can move on to the stroke discussion. Okay, and before I do that, let me just add one final thing for the venous supply about the danger area of the face. Now, I told you this is at the level of the eye. We have the nose. The facial veins that go, that is in the skin, they also drain here. Okay, there are two veins which drain here. Then the cerebrum drains here, facial veins. Okay, so basically the facial veins of this area, okay, will drain here. They will come to the cavernous sinus and go either, okay, there's another plexus. Okay, I'm not going to talk about that. It's called the pterygoid plexus. But basically the final route of these blood vessels is the internal jugular vein. Final route is it will go to the internal jugular vein. So all the blood in the brain, especially the front aspect, because the back aspect has another area, it's called the transverse sinus, will drain into the carotid sinus. Okay, now what happens if you get a pimple here and you pop it? Bacteria can enter into the veins. So if you get a pimple and you pop it, bacteria can enter into these veins. The problem is these veins do not have valves. Okay, so when that happens, each time you push it, you can push it all the way into the cavernous sinus. You can push it all the way to the cavernous sinus. And once you come here, I hope you guys know I'll tell you about the structure of it. It's like the bone marrow. You get trabeculae, basically. Okay, and if it comes here, it is very difficult to get it out. Because of the lack of veins, you can easily push these. Okay, if there are veins, you can stop it going backwards. Let me, how do I tell? Okay, let me just tell this. So basically, these are veins without valves. So if you press it, you will force the blood, the bacteria into the cavernous sinus. Okay, and that can cause a lot of diseases. It can actually kill you. Okay, so this is called the danger area of the face, because these drain directly to the carotid sinus. The thing is, the reason for the reason it goes to the cavernous sinus is because of the lack of valves. There's another vein which is supposed to carry the blood, external jugular vein. Usually it goes through the external jugular vein back to the heart. But because of the lack of veins, each time you push it, it can go backwards into the cavernous sinus. Okay, I hope you guys understand this. So that is called the danger area of the face. Okay. Next, we will talk about the diseases, stroke. We are done with the anatomy. We will talk about the diseases now. First of all, I will come back to this later, but look at this. Consider the motor one because it's the same, it's very similar in the sensory one. Basically, the anterior cerebral artery supplies the legs, the lower trunk. You can see the anterior cerebral artery, we will draw a diagram, don't worry, supplies the lower trunk. Middle cerebral artery supplies the upper trunk, posterior cerebral artery, it is mainly supplying the eyes. It is related to the eye. Okay, and we will talk about ischemic brain diseases now. So, can someone tell me what is ischemia? Can someone tell me what is ischemia?
Lack of blood supply.
Yes, there's no blood supply. Okay, basically it means the blood supply to an area has been cut off. So without oxygen, the cells that is dependent on the blood is going to die. So the first most vulnerable is the hippocampus. Most vulnerable. Next, we have something called the neocortex. Just write this. Next is the cerebellum. And we have something called the watershed areas. Sorry, this is not order. These are actually the most likely areas to be damaged. Okay, it's not an order. It's basically the areas which are most likely to be damaged. Now, ischemic stroke occurs due to three things. Let me just talk about ischemic stroke. The main reason is the reason is there's something blocking the blood flow. There's something that blocks the blood flow. And this area becomes oxygen deprived and they die. Okay, so these areas will die. The first type of stroke is called ischemic stroke. Okay, this is the first type of stroke we are talking about. This could be because of a thrombotic event. Okay, this is, can someone tell me what is a thrombus and what is an emboli? The other one is embolic event.
When a thrombus breaks apart and starts moving, then it's an embol.
Yes.
But
Exactly.
a clot just stays there, it's a thrombus.
Exactly. So a thrombus is something, I just write it as grows. Something that grows, I'll explain that. And the emboli is something that travels. Remember infective endocarditis, you can get a suppurative emboli. It can go to the brain and it can block a blood supply. Okay. So the third type is hypoxic. This is mainly because the entire body doesn't get enough oxygen. Okay, and that will affect watershed areas. That is basically, let's say you're in a surgery, okay, and you are given something, let's say too much of anesthesia. Anesthesia, one of the things it does is it paralyzes the muscles. What if you give too much and it paralyzes your diaphragm? You're not breathing, okay? And when that happens, the whole body does not get oxygen. So the brain, there's a certain area of the brain, which is called the watershed area, is going to lose the supply. Now, what is the watershed area? So it is the area labeled in blue, okay? These areas do not get blood from either the anterior circulation. This area is supplied by the anterior circulation. This area is supplied by the middle circulation, and these watershed areas gets the diffused oxygen, gets a diffused blood supply. Basically the waste, okay, the main vessels will go like this, and they will send some small ones which is not enough into those areas. This is called a watershed area. Okay, hypoxic events can lead to that. Now, I will just tell you this. The treatment of ischemic brain injury. Okay, I didn't explain this properly. A thrombotic event means something that is growing. This vessel is going to be occluded by something that is growing. Same thing that happens in heart disease. Embolic event, something that travels. Okay. Part of this, let's say a part of this breaks off, it goes and blocks the blood supply in a small artery. So this area will die. Okay, that is called an emboli. I hope you guys understand this. Now let's draw the circle of Willis. What I need you to understand is, usually the anterior ACA, ICA, MCA, and PCA. The reason our body has developed this circular structure is to try to avoid this situation. So what does that mean? Let's say there's some sort of a damage here. Let's say there's sort of there's some damage in this area. So the blood will be given to that area from this circle. But what happens if the damage is here? You don't have that circle effect anymore. Okay, so what happens then? This area, the entire area that is supplied by this, will undergo necrosis. It can die. That necrosis is basically cell death, okay, followed by inflammation. And what type of necrosis do we get? This is a pathology thing. There's coagulative, liquefactive, then yeah, caseous necrosis. What type of necrosis do we get? Liquefactive. Yes, brain always undergoes liquefactive necrosis. Simple, the name tells it, it becomes like a liquid. Okay, and the treatment is this. Okay, the treatment. So if you find, okay, let me take it like this. If it is within 3 to 4.5 hours of onset, you give something called tissue plasminogen activator. Okay. And if it is a large thing, if you're in the hospital, the doctors might decide to do a surgery. Okay, they might do a surgery to remove the thrombus. Okay, then you can reduce risk with medicines such as aspirin or clopidogrel. Okay, then you can control your blood pressure, control your sugars, sugar intake, stop smoking. So basically, and reduce fatty diets. Basically the things that is very general. And aspirin and clopidogrel, you will learn that in cardiovascular lessons that how people do. 3 to 4.5 hours of onset. So basically what we are trying to do is we are trying to dissolve that clot. Okay, we are trying to cause the platelets, stop the platelets from dissolving that clot. What happens If you give something like TPA, it helps dissolve the clot. If you give TPA, okay, you will learn this when you learn blood diseases, but basically what it does is it helps break the clot. TPA stops platelet activity. Now what happens if you misdiagnose this patient and instead of a clot, he's actually bleeding? If it is a hemorrhagic stroke, what happens if you give TPA? I hope you guys understand this. You have literally done the opposite of what you should do, and the patient can bleed to death. Okay. Remember, you need to make sure that you confirm it is a ischemic stroke before you start TPA. Okay, I will talk about the management later. Now, next, this is called a transient. Name tells it all, transient ischemic attack. Brief, reversible episodes of focal neurological dysfunction without acute infarction. There's no death of cells, so you won't see it on MRI. Okay? You won't see it on an MRI. I will teach you how to read an MRI. And they usually resolve in less than 15 minutes. Okay? So we will talk about focal dysfunction too, don't worry. Just follow this lecture as it goes. I hope you guys understand what is an ischemic brain disease or ischemic stroke. You can change this topic to ischemic stroke. Yes.
Shan?
Yeah.
What would be worse, the liquefactive necrosis or like internal bleeding? Like which is more severe?
Internal bleeding is way more severe. Trust me.
Okay.
This is like the final stage. When you talk about brain death, we talk about liquefactive necrosis. That area is already dead. Now it is being destroyed by the macrophages and releasing this liquid-like substance. It's not blood which comes out. Okay, this happens at the tissue level. It happens in the tissue level, not in the blood level. So this is the tissue level that will undergo liquefactive necrosis. We are not talking about anything in this area. Okay, we are talking about what happens to the tissue that was affected. I hope you understand. Okay, is that the question?
You answered it.
Okay. Now the other type of hemorrhage, it's called intracranial hemorrhage, and there are two causes. One is a congenital cause. It is called arteriovenous malformation. The first cause is something called arteriovenous malformation. Okay, I will explain that. The second one is due to an aneurysm. Okay, so the second one is due to aneurysm. So the aneurysms that we are concerned with are of two types. One is called perianeurysm. The other ones are microaneurysms. So what you need to know is perianeurysms affects the circle of Willis, which is found in the subarachnoid space. Okay, remember, circle of Willis is found in the subarachnoid space. These are small arteries which are in the brain parenchyma. So perianeurysm is going to cause subarachnoid hemorrhage. Rupture of a perianeurysm will cause subarachnoid hemorrhage. Rupture of the microaneurysms, there's a fancy word, Charcot-Bouchard microaneurysms. You will never have to worry about that name. It is in the brain parenchyma, within the brain. The small vessels that go from the circle of Willis gives rise to that. Now, let me talk about what is a arteriovenous malformation. This is a congenital thing in which, now if you have any idea about the pressure variation, you should know arteries are high pressure. Next, they branch off into arterioles. Arterioles. And they branch off into the capillaries. They form the capillaries. Okay. And the capillaries gives rise to venules, which form tributaries to form veins. Now, just to see your knowledge, can you guys tell me, do venules have a higher pressure or do veins have a higher pressure? Where is the pressure higher, venules or veins? Sorry. Is it A or B which has the higher pressure? Send your answer in the group. Guys, just send your answer in the group chat. Is it A or B?
Yes.
Just type A or B.
Venules.
Yes. Okay. Okay. I see that you guys know. Venules have a higher pressure than veins. Okay. Remember that. Basic physiology. Don't draw this. Please don't draw this. Basically, this is how the pressure changes. At the vein levels, okay, actually there's a sudden drop. Once you come to the capillaries, but basically, these are the capillaries. Right? So this is how it usually is. If you want, you guys can draw it. This is pressure. No idea what happened. I'm sorry. I have no idea what happened, but my connection disconnected. These are the arteries, arterioles. That's how it normally is. But what happens if this pressure is suddenly given to the veins? What happens if this pressure is suddenly given to the veins? Can someone tell me what will happen if this pressure is given to the veins instead of going through capillaries? The arterial pressure directly gives the pressure to the veins.
They'll burst.
Yeah. Simple understanding. Basically, what happens if this pressure is given to the veins is they'll burst. And that is the problem here. Arterioles connect directly to veins. This is called the AV malformation. Okay. I hope you guys understand this. And for those who don't know what an aneurysm is, it is an irreversible dilation of arteries. It's an irreversible. So the artery is supposed to go like this. Okay, the way I like to explain this is, let's say there's a junction. Let's say there's a junction, and blood is supposed to go like this. Blood is supposed to go in these two pathways. It comes from here and is supposed to go in these two pathways. But the blood because of the speed it is coming, it is going to go and hit this wall. It is going to hit that wall. So over time, the smooth muscles weaken. And when they become weakened, they are unable to maintain its shape, that they grow out like this. Okay. And over time, this can keep growing because the smooth muscles keep getting weaker. And over time, this can burst once it grows. Okay, for the abdominal aorta aneurysm, that is aneurysm at the abdominal aorta, once it's greater than 5 centimeters, there's a very high risk of bursting. Now over here in the brain, it is not going to be 5 centimeters, it is going to be way less. But this is what you call an aneurysm. Okay. I hope you guys understand this, because we are going to go into the discussion of bleeding. Okay. Sorry. We are going to go into a discussion of the bleeding. Now, strokes are of two types. They are either ischemic or hemorrhagic. And hemorrhagic stroke is of two types. One is AVM, the other one is aneurysm. Ischemic is of three types: thrombotic, embolic, and hypoxic. Okay. Now, guys, read this case. Read this case which I have given here for epidural hematoma. Okay. I need you guys to understand the dura mater. It loves the brain. Sorry, it loves the skull. I talked about two layers. One layer, no matter what you do, you can never separate it from the skull. The second layer, if you put enough pressure between the two layers, you can separate the two layers. And yet it loves the skull. Okay. So now we are talking about the first type of epidural hematoma. And especially for people in China, if you have a lesson called, what is it? Radiology, you will learn this there. Others, you will need this somewhere in your studies. So the first thing is, I'm going to draw the bone. Just don't fill this entire space. We need space. Okay. It's not circular, it's an oval shape, but okay. See, okay, this is the skull that I just drew. Below that, we have the dura mater. This is the dura mater. Don't draw this dura mater yet, because I need to highlight something. Okay, first thing I need you to know is, look at this CT scan. There are vessels that come from the circle of Willis and all those structures which go to the dura mater. Goes to the dura mater. Okay. And those vessels, those blood vessels, are present here. Don't draw this yet. I'm gonna erase a part of it. So if you, okay. Now you can draw it. Just draw a space like this and draw it. Draw it like this, Philip. And draw this. Just draw these suture lines. These are called suture lines. Now, here are the blood vessels that come from here, goes here. These are the blood vessels. Okay, you have the arteries and the veins. What happens if the patient has a fall on the side? Do you know this area, this weak area? Not only falls on the side. Let's say he gets punched there. So this patient, don't draw this arm, gets punched in this area. What is this area called? The weak area of the bone. This area in which three bones come and join, the temporal column. Yes. This is called the pterion region. This is very common in that area. Okay, this is the weakest area of the skull. It's called the pterion, P-T-E-R-I-O-N. Okay, what happens then? These blood vessels will be damaged and they will bleed. They will bleed and somehow they will separate the two dura mater layers. They will separate the dura mater layer like this. Okay, but the problem is when you come to the suture lines, suture is basically the connection between the bone. What is the connecting substance between two bones called? The connecting substance, is it called ligaments, or is it called, what is the other? Okay, it's basically the ligaments. Okay, so let me draw it like this. Here are the ligaments. Remember, ligaments are more stretchable. Okay, they can stretch compared to the bone. What happens then is, so here are the ligaments which I drew. They will stretch more like this. Okay, think of it like this. Will the bone stretch? Will the skull stretch outwards like this? It won't. The bone is the hardest substance. The ligaments are less harder and the dura is way less harder. So it is easier to stretch the dura mater compared to the ligaments. That is why we get this shape, and that is why we say it does not cross suture lines. I hope you guys understand. Okay, let me give you a name of this artery. It is called anterior branch of middle meningeal artery. Now, can someone tell me, is this dura mater a potential space or not? Wait, the other option is compare it with subarachnoid space and tell me, is this dura mater a potential space or not? Okay, it is not a potential space. Okay, that's why this is a problem. It cannot accommodate. It is not supposed to have this blood. It was never supposed to have this blood. Okay, so compared to the subarachnoid space, which is a potential space, okay, which is a space, this is not a potential space. Now, let me talk about how do you diagnose these patients. The first one, okay, if a patient was just had a contusion, that is the brain parenchyma was just affected, like there's no bleeding involved. The person Okay, let's take it like this. Unconscious after injury. In contusion, there's no bleeding. Recover rapidly. This is how you diagnose these patients. If you get a case, you need to know how to diagnose these patients. Remember, in a contusion, person might fall down. Sorry. Person might lose consciousness, but afterwards he's perfectly fine. When he comes back, he will be recovered fully. But what is this lucid interval? This is the key diagnostic feature. Okay, this lucid interval is the key diagnostic feature. What is a lucid interval? That is basically injury occurs and then he becomes unconscious. Okay, but he becomes unconscious or altered consciousness. Okay, and he will temporarily recover. I will explain this. But unlike the person above, in a contusion, this person gradually loses consciousness over hours or days. Okay, remember this, understand this. What happens here is, in a normal contusion, the person might become unconscious, but he recovers normal consciousness and is perfectly fine. But if the person undergoes a lucid interval, that means he might recover. He falls down at that moment, he comes back up, but gradually he worsens. Okay, he's over time he's unable to speak, or he's in a very blurred state. He doesn't know what's happening. It basically becomes worse. The reason for that is this keeps growing. So a patient who comes with these symptoms, accidental fall or after a fight, with gradual loss of consciousness, his normal higher functions are gone now. It's gradually going. You must immediately do a CT scan. Okay, you must immediately do a CT scan. I hope you guys understand this. In the CT scan, you get this convex shape. Okay, you get this, it's like a lens. You get this convex shape hematoma. You can see it here. If you look carefully in this diagram, you can see the hematoma. You can see the hematoma. This is a CT scan and this is an MRI. Okay, you can see the bleeding inwards. So the two things you need to know when you get a patient for this, first thing, you check for the lucid interval. Patient is rapidly deteriorating. Second thing, in the CT scan, you might see this. You will definitely see this if you get a question. The important thing is they do not cross suture lines. Okay. So there's a question: how do we diagnose transient ischemic attack if there is no, it's negative on MRI? So in the first lecture, I talked about people who faint and come back to normal. Okay, one of the causes is transient ischemic attack. That is basically not enough oxygen goes to the brain. He comes back, he's fine. This is a question I got. I just that's the answer. That is how you diagnose these patients, and these patients usually you do nothing. They're fine, basically. There's no long-term damage for these patients. Now, the next one is subdural hematoma. Hematoma is an accumulation of blood. Okay, I couldn't tell this, but it means an localized accumulation of blood. That is pathology. For any new students, hematoma is basically blood accumulated, like you can see here. Okay. Now, okay, this is how I like to remember this. This is not a mnemonic. It's just something I like to remember. I call it the frequent fallers club. Okay, there's a reason for this, because these are patients who have history of falling down. Now, let me explain this. Before that, I'll talk about why this is important. Now, I told you guys, okay, this is the skull. This is the dura layer. And okay, wait. Okay, sorry. This is the skull. This is the dura layer. This is the entire dura layer. Okay. And below that, you have the subarachnoid layer, the arachnoid layer. This is the arachnoid layer. Okay. And here, below that, we have the subarachnoid space. And below that, we have the pia mater. And touching the pia mater is the brain. This is the brain parenchyma. Okay. Now, this, I told you, our coronary blood supply, sorry, our blood supply, the arterial supply of the brain is floating around in the subarachnoid space. But the venous plexus must travel to the subdural area. Okay, it must travel to the subdural area. This is the area. It must travel like this. From the brain, it must travel like this. What you need to know is, can you see that our brain is enclosed in the subarachnoid space fluid? It's our entire brain. Okay, don't draw this, just try. Okay, it's fine. If this is the brain, if this is the brain, this is the pia mater, which you are supposed to draw, literally touching the whole brain. And the brain is floating around in the subarachnoid space. Okay. And here you have the dura mater. Outer to that, this is the dura mater. So what happens when there are sudden shocks, like when you're in a roller coaster, or when you're in a situation which is supposed to shake the brain, because it is floating around in the subarachnoid space, it can move around freely. Okay, but the dura mater, it cannot. So what happens if there's a sudden deceleration injury, like a car crash where you suddenly go and you stop, like because of you crashed, the vehicle stops like this. Then the brain will move forward. The brain can move forward because it is in that space, but the dura mater, which is holding this blood vessel, it cannot. What happens then? This will tear. Vein will tear. I hope you guys understand. Our brain, spinal cord, everything is floating around. But the veins that must pierce through, it can't float around like that. It has to be firm, stuck to the dura mater. So in a deceleration injury, a rapid deceleration injury, this can tear. And that can lead to the hemorrhage. It leads to the hemorrhage in this area, which looks like a crescent. Okay, let me draw it on the other side. The side which is not labeled. So it looks like a moon, half moon. It looks like this. Okay, I drew it in the same color, but basically it looks like a half moon structure because it's bleeding into that space, the space between the dura and the arachnoid matter. After a rapid, okay, let me talk about it like this. Let me talk about it like this. Acute. Acute is rapid deceleration injury. Okay. Or it could be, there's something called shaken babies. Nothing there. It's basically if you shake the babies in a very loving way, you can cause this damage. Okay. The other one is chronic onset. Why is this important? Because in elderly people, over time, the brain shrinks. The brain capacity goes down. Okay. Right now, that is a big issue in the American presidential election. Basically, these people have brains that are floating around more. Okay. And alcoholics, plus patients who have a history of epilepsy. They have, first thing, elderly, they have shrunken brains. Alcoholics and epilepsy patients have history of falls. They fall a lot. Okay. So whenever these patients have a history of falls, that's why I call it the frequent fallers. Okay. So if there's a history of fall, this can be an acute, this chronic onset person can be an acute on chronic. So if you don't know what acute and chronic means immediate onset, sudden onset. Chronic means long term, slowly developing. Okay, acute means immediate onset. Chronic, it slowly develops like this. So you can get acute on chronic. Okay, here is a diagram of acute on chronic. Basically, what has happened is when it is black like this, it means it's an old bleeding, old hemorrhage. This is an old bleeding, but this is a new bleeding. Look at the shape, it's like a crescent. These are all old bleedings. Okay. So the patient has old bleedings and he gets a new bleeding. Acute on chronic. That is, I hope you guys understand this. This is what I call frequent fallers. Okay. And so basically how these patients present is, so we have spent 2 hours now. Okay. I might have to do this class another day. We'll see. So the presentation of these patients are over days or years, or high speed deceleration injury. So these patients can either be this or this, and they have unexplained fluctuating levels of consciousness. Look, what does this mean? In the first one, you have to punch the fellow. So he has a history of getting punched. In this, you have a history of your head moving forward suddenly and stopping. Okay. That's why it says unexplained. Okay. So if when you talk to this patient, he has a history of falls, or if they have been using anticoagulant drugs, for a long time, if they are patients with something like hypertension, basically elderly patients, then you need to do a CT scan. Okay. Unexpected, this could be over days or years. Remember, they are frequent fallers. Okay. They can have, this is a past hemorrhage. This is a new onset hemorrhage. And this is important. In these situations, you can see that the ventricles, like when this is pushing from here, everything here must go inwards. You can see the ventricle has been pushed inwards. Okay. You can see it here also. The ventricle, which is supposed to look beautiful like this, like a butterfly, has its wing damaged. Okay, you can see it very clearly here. This is called a midline shift. The brain is supposed to be in the ventricles are supposed to be on either side of the midline, but it has shifted to one side. Next, subarachnoid hemorrhage. And okay, guys, I need you guys to listen to this, because this is the single most important way to diagnose these patients. Like, if you get a case about that is related to neurology, and you see the words worst headache, if you see the words worst headache, you can stop reading the question and you can directly put the answer as subarachnoid hemorrhage. Okay. If it is related to a stroke, if it is related to a stroke and you see the word worst headache, stop reading. I'm not kidding. Stop reading. Mark the answer as subarachnoid hemorrhage. Okay. I talked about some shortcuts when it comes to answering questions. This is one of them. Okay. Worst headache related to conditions of stroke, subarachnoid hemorrhage. Okay. There is one type of headache, but this is a headache which can also be called worst headache of their life, but it comes and goes every other day. This is a one-time thing. And the moment you see it, your answer should go to subarachnoid hemorrhage. But for the sake of completion, I'm going to tell you the other one where you get a very bad headache, especially in the morning, around the eye, and that is also considered a terrible headache. Okay, I hope you guys understand this. And this thing, I have been saying it like a mantra. The brain floats in CSF. If you guys have any doubts about this diagram which I drew, cerebral hemisphere, the temporal lobes, this is the midbrain, pons, medulla, and spinal cord. Okay. Now, I need you guys to get it into your head that the circle of Willis is present in the subarachnoid space. This is the pia mater. Make sure when you draw the pia mater, you draw it hugging the brain. Dura loves the bone, pia loves the brain. Subarachnoid is the awkward one in the middle. Actually, it loves the dura mater. Okay. Remember that. Dura mater loves the skull. It has a crush on the skull, but the poor male subarachnoid, the arachnoid matter, has a crush on the dura mater. Okay, it gets no response from the dura mater because the dura mater is in love with the skull. And while, okay, now what I need you to know is this is the diagram I'm going to use for this and intraparenchymal hemorrhage. Okay, remember the circle of Willis, write this in red. Circle of Willis is floating in subarachnoid space. That is basically in CSF. It's floating around in the CSF. So I'm drawing the, okay, I'm drawing the circle of Willis again. This is the circle of Willis, very ugly image. So you can get an aneurysm here. You can get an aneurysm here. And if you get an aneurysm here, it can cause damage to the third cranial nerve. Okay. Remember that. This is called a berry aneurysm. If that ruptures, so I will draw blood in red as circles like this. Blood will leak into the CSF. That is obvious. It has ruptured, and now you get blood in CSF. Okay. I hope you understand this. How do you diagnose these patients? The moment the patient says, it was the worst headache of my life, I have never had a headache like this, subarachnoid hemorrhage. And remember, when it comes to neurology, this is the most common case discussion that you can get. Most common case discussion you can get. Okay. So there are two causes, aneurysm or AVM. I forgot to include that in the note. Okay. Arteriovenous malformation. I hope you guys understand this. Okay, and you can see the bleeding has caused the circle of Willis to be beautifully illuminated. The bleeding has caused the blood to go around that area, and you can see it beautifully illuminated like this. Okay, if you do so, the first thing is check for increased intracranial pressure. Because it's bleeding, there can be increased intracranial pressure because it's bleeding and it is pushing everything to both sides. If that is there, okay, the first rule is you always do a CT scan. Okay, non-contrast CT, non-contrast. The other one is, give me a second, I got a message. Guys, I will give you guys a break the moment I finish this and this. Okay. Okay, let me finish this. I'll give you guys a break. It won't take long because we have done basically the major things. If there is no thing, intracranial pressure, you can do a CT scan. You have to do a CT scan. Again, non-contrast. I'll explain what non-contrast and contrast CT scans are. You can do a lumbar puncture. In a lumbar puncture, you can find RBC present. So in a lumbar puncture, you take out CSF, you take out this fluid. Look, you don't take the fluid from the brain in a lumbar puncture. You do it between L4, L3, L4, L5, over here, all the way down here. And yet you will see the red blood cells present because this is one continuous fluid. Okay, remember that. And for intraparenchymal hemorrhage, it is microaneurysms, which form due to hypertension. High blood pressure can cause blood to go hit the vessels, causing the wall to become weaker, forming aneurysms. Okay. Over here, we actually have the order. This mostly affects the basal ganglia, thalamus, pons, and cerebellum. And let me show you what this means. So the blood vessels will come in like this. Blood vessels will come in from the circle of Willis like this. If there's an aneurysm here and it starts, it bursts, you will get the microaneurysm. Burst, and you get hemorrhage. Okay. And finally, this is small. We talked about what happens to this, the blood vessel here. We didn't talk about what happens to the white matter. During rapid acceleration or deceleration, there can be damage to the white matter. Axons. And on a CT and MRI, you will see this is also bleeding, mainly of the, okay, think of it like this. The veins that go are not only, okay, no, let me give you the break. I don't want to confuse you guys. So you guys can take a 5-minute break, and then I'll teach you how to decide which area has been affected in a stroke. Okay. So take a 5-minute break. I hope you guys have understood everything. I'll be here. If you have any questions, you can ask me. Guys, if you have any questions, please use this time. Okay, guys, let's start this again. And so there are some, okay. So some of you might know that I participated in the software design competition. That was a part of an all China competition. And I made a software which won provincial first in Jiangsu. Okay. Okay. So the software that I made, it won provincial first in Jiangsu, and it won second place in the whole of China. This is the software that I made. It detects hemorrhages on CT scans. You can see the red markings. It detects hemorrhages on CT scans. Okay. So these are all hemorrhages of the brain. And let me just show you something. This area, can you, if you guys can see my mouse moving, just give me a thumbs up. Can you see the mouse moving? Okay, perfect. So this is the crista galli. Over here is where the cranial nerve 1 will come and go out. This area is where the eye will be found. Okay, you can see the eye. Here's the eye forming. So basically, when I had to make this software, I had to self-study everything to do with CT scans of the brain and everything, which I will teach you guys over time. But let me remove the hemorrhage. You can see the hemorrhage. You can see the white on CT scans like this is fluid. If there is white on a CT scan, that means it's fluid. In this case, it's blood. The darker structures are more harder. Okay. So the other structures on the side are the brain tissues. Okay. So you can see the hemorrhage. You can see, can someone tell me, does this look like a subarachnoid, or what is the type of hemorrhage? Just think, this is all around the ventricles. You can see it's all around the ventricles. Is this a subarachnoid hemorrhage, or is it an intraparenchymal hemorrhage, or what? Here you can, this is the ventricles, this black area, that is the ventricle. Is this a subarachnoid? Yeah?
Subarachnoid.
Intraparenchymal.
It's subarachnoid. This is a very serious hemorrhage, but it's a subarachnoid. You can see it involves the ventricles. Okay, let me see. I'm not sure. I just realized I can use this. Let me see if I have another. Okay. Can someone tell me what this is?
Intraparenchymal.
Think again. Okay. Wait. Look at this and tell me. Subarachnoid or intraparenchymal?
Intraparenchymal.
Yeah. Okay. Actually, sorry, I made a mistake. This is also subarachnoid. I made a mistake. Sorry. This is, the reason is, if it was coming from here in this, it is an epidural. If it is a crescentic shape like this, it is a subdural. But if it is present diffusely, it's all over the brain, that is a subarachnoid hemorrhage, because it's present in the CSF. Okay. And if it was localized, if it was just one location, let's say I don't have a proper image here. If it was something like this, a localized one, it is an intraparenchymal. Intraparenchymal is localized to one point. in that area, look, okay, we'll go check the lecture again. Give me a second, it's connecting. Okay. So look at this. It's fully focal. One location, even when you go down in the CT scan, it will be in that location, and at a certain point, it will disappear. Okay. But subarachnoid, you can find it all over the place, like this. And there are micro vessels, like there are small vessels which are in the so the parenchyma is going to be filled with small vessels. If there is rapid acceleration injury, remember the veins that couldn't move around, those can be damaged. So you get tiny focal, like it is very tiny and it is very focal. Okay. This is a very rare condition in the sense you will never get this for any exams, but for the sake of completion, I'm giving it. This is actually the most dangerous one. These will cause damage to the axons, and it is very difficult to treat and detect these hemorrhages. Okay. Now we'll talk about the effects of stroke, and this is actually the secret to diagnosing any stroke. What do I mean by that? Okay. So the first one, we'll talk about the anterior circulation strokes. Okay. Just draw this with me. This is the brain, basic structure of the brain. Okay. This area is the frontal lobe. This is the posterior aspect. Here's the cerebellum. Okay. Now, what is this?
Cerebellum.
No, this which I just drew over here.
Oh, the,
It's the precentral sulcus. Okay. I need you to draw a man here. Look at the way I draw. Here is his face. Here is his tongue. And here is his body. This is his body. This is his arms. Just draw this. What I drew over here is his tongue. Okay. The reason you draw the tongue big is because there's a lot of motor and sensory innervation. Taste. Okay. Literally, 3 cranial nerves go there. Okay. Now, I need you to highlight certain areas. This area is supplied by the anterior cerebral artery. Okay. This area is supplied by the middle cerebral artery. Now we are looking at the brain from the side. We are learning to diagnose which artery is damaged in the way that does not involve doing extensive CT scans and everything. The patient comes, and based on the symptoms, you need to be able to tell, or at least make a guess, which is damaged. So let me label this. This is the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. Okay. Now think and tell me. Look at this image and tell me. So is the front part related to motor, or is the back part related to motor? From the central sulcus, precentral sulcus, is the front part of that related to motor, or is it the back part?
Front part.
Front part. Okay, remember that. So in this case, if there is damage to the anterior cerebral artery, Remember, if there is damage, don't draw this. If there is any damage here, it will affect both sensory and motor of which area? In the body, which area is going to be?
Lower limbs.
Yes.
Lower limbs.
And remember, I hope you guys know, I have told the people who have done the lectures before with me, I have still not told you a situation where you get ipsilateral, same side damage. Okay. Today is the only place where you will learn the ipsilateral damage thing. Over here also, if the right side is affected, can someone tell me which lower limbs will be affected? Is it the right side or the left side?
Left side.
Huh? Think again. Actually, it's the left side. I still didn't come to the ipsilateral part. Remember the corticospinal tract, don't draw this. From the brain, it crosses at the, remember this. This is, just don't draw this. So in the medulla, it crosses. The corticospinal tract, it crosses. In this case, we have damage to the right side. This fiber travels all the way to the left side. Okay. And when you talk about the this damage, can you understand it is going to be the left side affected? Opposite side, it's contralateral. I just showed the what is it? Corticospinal tract, that is the motor tract. But same concept for sensory tract, because they also cross at the level of pons, as I remember. I need to check that. Do you understand this? So there's going to be paralysis and sensory loss. Basically, that side is useless. The patient's lower legs on the left side, he can't move, he can't do anything, he can't even feel it. Okay? There's nothing to memorize, everything is to understand. Okay? This is why I love neurology. There's two ways you can study this. One is by memorizing, the other one is by understanding. MCA, it is going to give sensory and motor to upper limbs, upper body. Let me put it as upper body. Okay. So if there is right MCA stroke, here, guys, please label this as diagram 1. Okay, we have several diagrams, and right now we are talking about the effect on motor and sensory of the person. Right MCA stroke. Sorry. Yes, sorry. So right MCA stroke, left upper body affected. I love how this happens. Basically, he will be like, do you remember Two-Face in Batman? You remember Two-Face in Batman? he has one evil side and the other side is normal. Same situation here. Instead of it looking burnt, he will have a paralyzed side on one side, the other side is normal. Okay, he will not be able to move this lip. This side of the lips he cannot move. So basically, it's like two-face. Now, can someone tell me in which side of the brain do we get our language center?
Most of the times it's the left hemisphere, but
Yes.
sometimes it can be right.
Yes. Okay. Remember this. In patients, okay, not patients. Give me a second. Okay, guys, so I want to finish this lecture today. It might go till, let's say, Sri Lankan time 11 p.m. If you guys have to leave, I will upload the section, just the section from 10 p.m. to 11 p.m. on YouTube. Okay, you guys can watch that. But I want to finish this lecture today because thank you. Yeah, I can't carry this forward. Now, again, I'm drawing the brain. Okay, I turned the brain the opposite side. Let me draw it. Okay, let's draw it like this. I need you guys to understand this is the cerebellum. Basically, I turned the brain around. Okay. The reason is I had drawn it like that that's what is in my memory. Okay, what is the color used here? Blue. Wait. Same thing here. In this case, we have two areas. Let me draw. There's two areas. The first area, why does it keep filling? This is on the temporal. It's on the temporal lobe. It is called the Wernicke's area. And there's another area which is called the Broca's area. Look at this image and tell me, this is the anterior aspect, this is the posterior aspect. Is the Broca's area involved in motor activity, or is the Wernicke's area involved in motor activity? Look at this image and tell me that. Broca's area, is it involved in speech?
Broca's involved in speech because it's in
motor.
Yes, remember that. Broca's area, from the location you should be able to tell, is involved in speech. Okay? Speech. And if there's a stroke in the MCA of the dominant hemisphere, I will come to that. What can happen? Will the person be able to talk properly? Will he be? No, it's very simple. He will have slow or poor speech articulation. And this is called expressive. We will do this. one of our next lectures is on language center, expressive aphasia. We will do this, don't worry. Now, Wernicke's area is related to perception. Okay. This is involved in perception. And these patients, if they have a stroke in dominant hemisphere, they can have aphasia. Sorry, this is called receptive aphasia. That is basically poor comprehension. Okay. So tell me this. Let's say the damage is only to this area, the supply to the Wernicke's area. Will this patient be able to talk properly? Will this patient be able to talk properly?
Yeah, but he won't give correct answers.
Yes, exactly. It's basically, see, when I highlight this area, I'm just highlighting the entire middle cerebral artery. Okay. It has branches, and the stroke will affect most likely a branch. Okay. If it hits the entire MCA, the person is most likely dead. He will be paralyzed. He will be in a coma. Every possible thing that can happen will be there. Okay. If the branch that goes to one of these areas is stroked, you should be able to understand. Okay. What I need you to understand is not memorize. MCA is like this and is on the side, lateral aspect, and on the side you have the language centers. Okay. So if those are damaged, you will have these conditions: poor comprehension, but may have normal speech. This is receptive aphasia. I tried my best to not use big words, but for any new students, contralateral means opposite side. Ipsilateral, IPSI, lateral means same side. Okay. And the third one is this is lenticulo a second. Look, I got a question earlier asking if the internal capsule is going to be supplied by the anterior cerebral artery or the middle cerebral artery. I'm going to answer that here. This is a big word, but those who did Parkinson's with me should know what this is. Okay. Okay, let's see. Can someone tell me what is the striatum? What is the striatum made of? What is the striatum made of? I'll let you guys think.
Putamen and the caudate nucleus.
Yes, cuneate nucleus.
Cuneate.
Okay. For those who weren't part of the last lecture, let me show you guys the basal ganglia. This is a pure motor stroke involving the basal ganglia. Basal ganglia is related to our motor function, movement. This is the structure which is affected in Parkinson's disease. So I'm going to quickly draw the entire structure around the thalamus. If you guys can draw it, but then I'll draw a summarized image. Okay. We have already done this. So here's the thalamus. It looks Y because in the middle you have a gray matter region. Okay. It looks like a Y because you have a gray matter region which separates the thalamus into 3 segments. Below that, you have the subthalamus. Below the thalamus, you have the subthalamus. And there's going to be a bundle of white fibers. Okay, before that, let me draw this is called the lentiform nucleus. This is called the lentiform nucleus. Okay. The lentiform nucleus is made up of 2 parts. One is called the putamen, and the medial part is called the globus pallidus. Okay, I shouldn't label it because I won't have space. You guys can draw this all, both aspects, both sides. Here's the thalamus. Okay, let me keep the labeling on one side. So I'm drawing what is between the 2 thalami. What goes between the 2 thalami? Huh? Sorry, guys. So let me recap. This is the 3rd ventricle. Here's the lentiform nucleus, which is a combination of the putamen and the globus pallidus. And this is the subthalamus. And what I just drew in green is the internal capsule. Internal capsule is a very important structure because it carries the motor fibers to the brain. Since it's basically a bundle of white matter. Simply that, okay? And then we have the caudate nucleus, which it basically starts from the from this area. The head of it starts here, and it goes on top of the thalamus and goes underneath the lentiform nucleus and forms. It has a nucleus called the amygdala. Okay, it forms a circular nucleus underneath the lentiform nucleus. I'm going to draw this structure again on the other side. It comes down and terminates like this, and that is called the amygdala. And to this, we have the hippocampus joining. Okay. the hippocampus joins there. That's a different lecture, but basically the hippocampus joins there. Now, this is the structure of the basal ganglia. There is one more important structure, which is a part of the midbrain. It is a black area. This area is a black area. It's in the midbrain. Can someone tell me what this structure is?
Substantia nigra.
Yes, this is the substantia nigra. And can someone tell me what I'm highlighting right now is? What did I just highlight?
Pars compacta.
Yes, it's a pars compacta. That's where you get the dopaminergic nerves that are affected in Parkinson's disease. We have done this. Okay. This is a basic diagram of the what is it? Basal ganglia. Okay. And whenever there is an internal capsule, there is an external capsule, which is present here. It's thin. Okay. It is neglected because it's useless. It has a function, but when you look anatomically, you always forget that structure. Okay. I hope you guys understand this. Just for the sake of completion, we have the medial and the lateral geniculate bodies. And then we have, you guys should remember this. Over here, you have the thalamus, all those structures. So now I'm going to erase this and just draw the basal ganglia. Okay. A summarized version of the basal ganglia, putamen and globus pallidus. And over here, I'll draw the caudate nucleus. And internal capsule is not a part of it, so I will leave that out. Draw the thalamus. This is the subthalamus. And in the bottom, you have the substantia nigra. Okay. Now, those who did this lecture with me, you should be able to remember putamen and caudate nucleus together is called the striatum. And this is the lentiform nucleus. That's where you get this name. Okay, this is a pure motor stroke in which these patients will have contralateral paralysis. No cortical signs. This includes aphasia, vision lost, nothing like that. Okay, because I told you this is at the base of the brain. I need you guys to understand this. Look at how many words I have given and look at how many diagrams I have given. Try to understand, not memorize. Okay. The next one is the posterior cerebral artery strokes. Okay. Now, posterior cerebral artery strokes, if you have learned this in your universities, perfect. Basically, what I'm drawing right now is the two sides. Okay. This is the brain, and here are the eyes. Okay, guys, we need some space above this. Sorry for that. To draw the field of vision. Guys, anyone who needs to leave at 10, you can leave. I will upload the remainder of the class on YouTube. If not, we'll continue. Okay. So basically what I'm drawing is the thing you learn in anatomy about the visual defects. Now, what you need to know is reception, like the reception of vision is like what your eyes see comes to this area. Okay. What your eyes see comes to this area. This area is supplied by the posterior cerebral artery. What your eyes tell you it saw is mainly it's on the more lateral side. This is supplied by the middle cerebral artery. That is basically the higher functions. Your eyes, vision and everything is controlled by the posterior cerebral artery. In the sense, it is supplied by the posterior cerebral artery. Then it will send the signals through nerves to the MCA innervated areas. Okay, that means image processing happens in those areas. So if there's a stroke in this area, what happens to your vision? We will discuss this in another class, but basically this has a fancy name. This is called if there's any damage to that area, that means if there's a stroke in that area, it is called contralateral hemianopia with macula sparing. If you have already done this, you should understand what this is. If you haven't, we are not going to talk about that today. We will talk about that later though. It's a huge lesson. Okay. Now, this is PCA damage. Now we will talk about the higher order functions. This is processed in the temporal lobes. Why is this important? It means you can see but can't distinguish. So normally, in a normal eye, the person will see. Let's talk about a cup of tea. Your mom gives you a cup of tea. This is what you see. But damage, you cannot distinguish it. In the sense, you see something, but you cannot distinguish it from other things. Is it a pencil? Is it a cup? Our brain cannot tell you that. Okay, I hope you guys understand this. Now, the anterior circulation affects sensation and motor of the lower limbs. Everything else that we discussed is affected by the middle cerebral artery, and vision is affected by the PCA and also the cerebellum. Okay, remember the cerebellum is affected, and for this I need you to add one more thing. There's something called alexia without agraphia in the dominant hemisphere. If the stroke is in the dominant hemisphere, the stroke is in the dominant hemisphere, just write that. Okay, next I want to talk about, give me a second, I need to check what is next. Okay, so one common complication, actually one of the first patients, I have been to hospitals in Sri Lanka and I have done neurology in China. So basically one of the first patients I saw in Sri Lanka, one of the first patients I saw in Sri Lanka was a stroke patient who went into status epilepticus, recurrent seizures. Okay, the person went into status epilepticus, that is recurrent seizures, that is due to strokes of the cerebral cortex. Just know it like that. Okay, I have taught you guys the way these signals go. It's a huge thing. I cannot, do I have it in this note? Wait, let me check. Yeah, so that is basically, we have done this. I will see if I have saved the videos. If so, I will upload it and you can watch the topic on seizures. The other one is coma. Okay, let me just explain this because we need it for both. This is due to large volume hemorrhages that can affect, that is affecting the reticular activating system, okay, RAS, reticular activating system. Let me show you guys, remind you guys, what I'm describing right now is 5 and 6. Okay, so this is the anatomy of the reticular activating system that I'm drawing. My brother wants me to join him to play some games. Okay, so if you don't know what I just drew, cerebrum, temporal lobe, this is the, oh wait, this area is the midbrain, then the pons, medulla, downwards. Okay, now here is the thalamus. You have the thalami here. Okay, and you have this sheath of nerves that are especially responsible for you being awake. These are basically involved in two things. Okay, this is involved in checking how it keeps you awake basically. Okay, so basically this is called the reticular activating system. It also gets fibers of pain and temperature. Can someone tell me the pathway that brings pain and temperature?
Spinothalamic.
Spinothalamic, yes. Spinothalamic. This is from both the face and so basically it receives pain and temperature from both the face and the lower body. Okay, and it sends signals. It comes to the thalamus, and the thalamus basically activates the entire cortex. This is how the body makes sure that you're awake and functioning. Okay, so give me a second. I want to explain it the same way I did here. Okay, this is how I explained it. Basically, what happens throughout the day? Okay, what happens during the night is the neurotransmitters, when you're sleeping, they get replenished. They get filled up again. Okay, so this area, the neurotransmitters in all these nerves, they get filled up, ready for the next day. So in the morning, you're full of energy because all your neurotransmitters are active. Okay, now its function is cerebral arousal. If these reticular formation fibers overfire, it can lead to epilepsy. If these cerebral fibers overfire, it can lead to epilepsy. But if it is underfired or if it is suppressed, it can lead to coma. Okay, so this is basically the on-off switch of your nervous system that tells you when to wake up and when to go to sleep. By the evening, you're tired out because our brain has been active. Think of it like this. On a day where you're not busy, on a day where you are not really busy, you're at home, you can stay the whole night. You're not tired. Okay, that is because the neurotransmitters are still present. It's not been used up already. But on a very busy day, you go to the gym, you work out, you're fully tired. You're basically fully tired. That is because you don't have any neurotransmitters. So by around 9 o'clock, you're in bed sleeping. Okay. And when you're asleep, it's basically shut down. It's shut down so that even if you touch the patient or you give him mild pain or mild sound, the patient will not wake up. Okay, not the patient, the person will not wake up. Okay, but if there's a stroke here, remember this, it can be overactivated. Something can happen and it can be overactivated, leading to epilepsy. Or it can be damaged in such a way that it leads to coma. It's inhibited, leading to coma. Okay, what is a coma? It is the brainstem functions are working, but cerebral cortex is switched off. Okay, I hope you guys understand this. We have done that. Okay, I didn't expect to go into detail for that, but I had to. This. And let's talk about the posterior circulation now. We finished the anterior circulation. This is actually the big part. Posterior circulation. Look, I need you guys to understand, this is not about memorizing. Your university will give you things to memorize. This is about understanding. So when you study your university note on stroke, I would suggest you go through this once, then you start memorizing whatever is given in your university. Okay. And the thing is, universities, they tend to selectively decide what is needed. Okay. So in a country like China, they will not talk much about MS, multiple sclerosis, compared to a country like, which is above in the equator, like which is way above, because there's how to say, there's research that says MS is caused due to the geographical location. Okay, so countries like US, they will focus a lot on MS compared to a South Asian country or something below. Okay, now posterior circulation. The first one I want to talk about is the anterior spinal artery. Okay, again I repeat. Oh, sorry. Give me a second. Now we are talking about the posterior circulation. Okay, and the first one is anterior spinal artery. Okay, if the anterior spinal artery is affected, it damages the corticospinal tract plus medial lemniscus. It is one pathway. We did this for spinal cord. It's basically the motor tracts and the hypoglossal nerve. Can someone tell me which nerve is this? Which cranial nerve is this?
12.
12. Okay, remember that. So let me draw a diagram, a simple diagram, nothing complicated. Spinal arteries will be somewhere in, I didn't talk about that much. Right. So our vertebral arteries, it gives rise to the spinal arteries. Okay, our vertebral arteries gives rise to the spinal arteries. Remember this structure? So remember I told you cranial nerve 12 leaves from this area. That is the hypoglossal nerve. Remember that? And also remember, this is where fibers of the corticospinal tract come and cross. Somewhere here, they cross. And I told you, anything that touches or is around the corticospinal tract, remember the corticospinal tract actually goes down. We have done this for anterior stroke, anterior spinal artery stroke, anterior, this is basically the same thing. The only thing we are adding is that the hypoglossal nerve is affected. Okay, same thing. If it happens in the brain stem, the hypoglossal nerve is affected. Okay, so what we get is contralateral paralysis. Contralateral paralysis. Can someone tell me, is the upper limbs or the lower limbs affected or both? They can tell me.
Both.
It's both.
Both.
both upper and lower limbs are going to be affected. Plus, there is a decrease in contralateral proprioception. Just write that down. That will not be needed. Plus, ipsilateral hypoglossal deviation, damage. So tongue deviates ipsilaterally. I'll explain this. Now you can see that the cranial nerve has left here. It has already left. This is the first place you get ipsilateral. And I'm explaining that now. You can see the cranial nerve has left and the stroke has happened. So the cranial nerve, which is going this way, will go and innervate the tongue of that same side. So this is the right side, right tongue. And if there is damage to that, the person will have his tongue protruded towards the right side. When you tell the person to put his tongue out, he will not be able to put it straight. He will put it. I hope you understand. He will not be able to put the tongue out straight. Okay. Don't worry, we have just a little more. The last part is very fast. Second one. This is the most important one. This is called Wallenberg syndrome or lateral medullary syndrome. This will definitely come in your final exams of your ERPM or whatever licensing exam. This will, if a question from stroke or something appears, this will be there. Okay. The reason I tell you this is, remember, this is a stroke of posterior inferior cerebellar artery. Okay. Remember, I told you this. Okay. Did something happen? No. Let me just quickly draw a diagram. So we have the fourth ventricle and we have cranial nerves 9, 10, sorry, it's laterally is 9, 10, 11. 9, 10, 11. Same thing on the opposite side. Okay. And right in front, we have a very important nucleus called the nucleus ambiguous. Okay. This is the nucleus ambiguous. Okay. And for the sake of completion, here is the olive pyramid olive structures. There's a lot more. There's a lot more structures to add, but basically just know this. And from here, we have the cerebellar peduncles. Okay. We have the cerebellar peduncle, which goes behind. Now, what is important is if a stroke affects the pica, it will hit all of these. It will hit all of these. Posterior, inferior cerebellar artery, because the anterior inferior cerebellar artery will hit these areas. Okay. Do you understand this? This is for pica. So when cranial nerves 9, 10, 11 are affected, okay, nucleus, ambiguous. The patient will present with dysphagia, hoarseness, decreased gag reflex, hiccups, basically anything related to do with something coming out or going in, either you talking or something like vomiting. You should know the functions of cranial nerves 9, 10, and 11. Okay, when cranial nerve 10 is affected, there is a branch which it's called the recurrent laryngeal nerve. If that is okay, if the start of the nerve is damaged, that means even the bottom parts are damaged, and he will have hoarseness, difficulty speaking. He will also have difficulty swallowing. That is also related to cranial nerve 9. Okay, do you guys understand this? So in addition, the patient will have damage to the spinothalamic tract and spinal trigeminal nucleus. Now, the cranial nerve 5 has 3 branches, 3 nuclei. One of them actually originates from the spinal cord and goes upwards like this. It is called the spinal trigeminal nucleus. Okay, so if these are affected, one of the functions of the trigeminal nerve is pain and temperature from contralateral side. And if the sympathetic tract, the reason why this is most important is this is the biggest section that is going to be affected. The sympathetic tract can also be affected. Okay, I don't have a diagram to show you, but I'll send you an image later. That can lead to, can someone tell me what happens if the sympathetic tract is damaged? What is the syndrome? Remember this, we have done this. I have explained this. The reason why we get Horner syndrome is from the level of T1, you have the sympathetic tract starting that goes and gives innervation to cranial nerve 3 and cranial nerve 5A. That cranial nerve 3 damage can actually lead to drooping of the eyelid, inability to 3 things: meiosis and hydrosis. Failure to sweat and hydrosis. Hydro, water. A means whenever you add an A in front of something, that is absent. Meiosis is contracted pupil. Ptosis is basically drooping eyelid. Remember, in a fight or flight response, you need to have a dilated pupil. So when there's damage, there's going to be this affected. And if there's the damage to the inferior cerebellar peduncle, can lead to ipsilateral ataxia and dysmetria. So I hope you guys understand, even though I drew the damage to both sides, the damage will be most likely, there's always 2 vessels for either side. It will be one side, okay? And you should be able to understand. Okay, so the spinal trigeminal nucleus situation is like this. It goes to, it joins with the Edinger-Westphal and another nucleus, the pontine nucleus of the trigeminal nerve, and it crosses to the opposite side. Okay, that is why you get contralateral side. Okay, I hope you guys understand this. This is the most important one in today's lecture, and I will quickly tell you about the other things. That one is anterior inferior cerebellar artery. This is called lateral pontine syndrome. Okay. So just to save some time, I will not give you guys any diagram for this, but basically it affects the facial nucleus. So can you guys tell me this? Is the trigeminal nerve or the facial nerve involved in muscles, movement of the face? Trigeminal or the facial nerve? One is for sensory, the other one is for motor. That is expressions, all these.
Facial.
Yes, facial nerve is involved in all to do with movement of the muscles, facial expressions, all of those. Trigeminal nerve, sensation, and there's 3 nuclei. The spinal nuclei brings pain and temperature. Okay, I hope you guys understand that. Look, it brings it, sends it to the cortex. Our brain processes every information. Facial nerve is affected, so paralysis of face. Okay. There's going to be facial drooping. This is very important. Okay, facial drooping of one side. It is usually due to this. It's like facial palsy. I hope you guys know. Facial palsy, it'll be the same thing. Okay. Then, okay, vestibular nuclei. Actually, over here also, even though I didn't mention it, you have, okay, no need. I need to include that also. Vestibular nuclei, sorry. I just remember. There is vomiting, vertigo, nystagmus. So read the name vestibular nuclei and tell me what is its function. What is the function of the vestibular nuclei?
Balance.
Yeah. So basically, when that is affected, it leads to symptoms like vertigo, nystagmus, and when there's no proper balance, it can cause you to vomit. Okay. Remember, nausea, one of the causes is something to do with your ear. Okay. And again, you have these same things. Sympathetic tract. The thing is, right now we are talking about the damage to this area. Okay, this is actually in the pons, that is above, but basically should I draw? No, that will be, the thing is I have to draw the diagrams of the pons and everything later in lessons. I will do that then. So remember this labyrinthine artery? That can also be affected because I told you, I talked about this. It goes with 7 and 8. Okay. Ipsilateral sensory neural deafness plus vertigo. Okay, and sympathetic tracts. First and middle and inferior cerebellar peduncles. So basically, it's the same thing as above, but instead of affecting the 9, 10, 11 nuclei, we are talking about affecting 6, 7, 8, especially 7. Okay, same thing as above, nothing much, same thing as above. Problem here is, okay, when a patient comes, if the patient doesn't have any problems with the face, but has the other symptoms, you can tell it is a Wallenberg syndrome. We actually have a case here. You guys can do that later. The last 2 parts, this will be fast. Basilar artery, the big one. Okay, if this is damaged, 3 things. So basically what happens is, if RAS is damaged, reticular activation system is damaged, the patient can go into a coma. And this is the big artery that is going to supply literally all the descending and the ascending tracts. That is basically the corticospinal tract and everything, corticospinal tract and corticobulbar tract. Corticobulbar is facial muscles. It's basically the corticospinal tract related to facial muscles. So if this is damaged, it can lead to quadriplegia. This is called locked in syndrome. Look, I need you to understand, in this situation, the patient can't move a single body muscle, mouth, nothing, face, nothing. If that happens, the patient is conscious. He knows everything that's happening around him, but he can't tell that he's fine, that he's conscious. The only thing he can do is he can move his eyes around. Okay? He can move his eyes, can move vertically. Okay? The eyes can move vertically, not side to side. Remember, basilar artery is the big one. Okay, and we have now finished the main things. Now it will be really fast. Let me quickly, it will take me like 10 minutes to finish this whole thing. Not even 10 minutes. Now, how do you distinguish between a cortical stroke and a brainstem stroke? These strokes have focal symptoms. Okay. So what does that mean? Can someone tell me? We are talking about the arteries that supply the cortex. If that is damaged, can someone tell me? Okay. Can someone tell me? We have 3 options. Can someone tell me, in a left leg, if the patient's left leg is paralyzed, which artery is affected? And
The
previous,
anterior.
yes, right side. Remember that. ACA, right side. If the right face is paralyzed, or paralysis sensory loss, right face. Remember this, MCA, the left side. MCA of the left side. Remember these diagrams? Middle cerebral artery. The legs and everything is of the lower legs. It's from the ACA. I explained these. One more. We'll do one more. Vision center.
Posterior.
Yes, PCA. Okay. Focal symptoms affecting just one region. So it is two. Okay, it is actually the easy one. The next one is diffuse or generalized. If you have a brainstem stroke, the symptoms are more diffuse. Okay. Let me tell you guys. So I showed you how the cranial nerves are located. Let me summarize it in an image like this. Guys, we are almost done. Don't worry. So let me just summarize this. This is the midbrain, pons, and medulla. Cranial nerve 3 and 4 are medial. Remember, these are motor nerves. Cranial nerve 6 is also medial. Cranial nerves 5, trigeminal. Cranial nerves 7 and 8, they are more lateral. 12, 9, 10, 11. The way I remember this are motor are midline. Sensory are lateral. That's all I remember. Okay, let me do a case and I will explain this. So the first case, 59-year-old with 7 hours of various neurological symptoms. The moment you see that, you should understand it's a brainstem. Okay, and also this says but he can't detect pain on his entire left side. On his left side. So the spinothalamic tract is affected. Absence gag reflex, drooping eyelids, tongue deviation to the right. So can you guys tell me what is the artery that is affected? Is it the pontine arteries or the medulla? Look at this and tell me. Okay, guys.
Medullary syndrome.
Yes.
Medulla.
Yes. Lateral medullary stroke. Is it the left side or the right side? Right or left? It's one of these two answers.
Contralateral side.
Yes, basically the right. Right lateral medullary stroke. This is what you call Wallenberg syndrome. Okay, I need you guys to kind of memorize this case because this is very common. So let me see. I need this can confuse you. So just delete that. Just delete that. That might confuse you. Over here, I showed you the nerves that are medial and that are the ones that are lateral. Okay, that can confuse you. Can you guys try this case? Is this a brainstem stroke or not? First thing, brainstem stroke or not? Okay, let me just, for the sake of the future you who might look back at this, I will explain this brainstem stroke. Okay, if you guys didn't delete this, just keep it. If you did delete it, it's fine. Sensory, that is the spinothalamic tract, is lateral. Okay, cranial 10 is lateral in the medulla. Absence gag reflex. Drooping eyelids, sympathetic chain. Which is also actually found lateral. Remember PICA strokes. And right cranial nerve 11 is lateral. Okay. If you guys didn't erase this, I said motor are midline. The reason I told you to delete it is I thought you might confuse yourself. Corticospinal tract is what we talk about if there is paralysis. Sensory are lateral. This is spinothalamic and dorsal column. When you talk about these, so for the next one, let me just give you the answer. The answer is B. This is a brainstem stroke. Second one, it's a motor. Corticospinal tract is affected, so it's a midline stroke, a medial. And left weakness means it's a right-sided stroke, right side stroke. And cranial nerve 6 palsy, midline. The reason you might not be able to understand how to decide if it's pons or not is because you may not have learned these cranial nerve 6 function and everything. He's unable to move his eyes laterally towards the left. Remember LR6? Lateral rectus moves it to the left. Okay, guys, we are done. In terms of management, I will quickly go through it. It will take me like a minute or two. So when it comes to management, first rule is these are emergency situations. In any emergency, the rule is you have to do the ABC, airway, breathing, and circulation. Okay. Next, you need to take his history, and from the history, you realize that this is a stroke. The next thing you do is you ask the patient to do a non-contrast CT scan, because if you give TPA to a hemorrhagic stroke, it can cause further bleeding. That is, the CT is the gold standard for stroke management. Okay, because CT detects hemorrhagic stroke immediately, but ischemic strokes take 6 to 24 hours. And since countries like Sri Lanka and actually around the world, you do a CT, not an MRI, because MRI is more expensive and it's not really accessible to everyone. If you can do an MRI, you will see ischemia in 3 to 30 minutes, but that is actually out of the question. So CT will show hemorrhagic stroke immediately, but ischemic changes, it will take 6 to 24 hours. And ischemic stroke, the way you read a CT scan is, those areas are darker than the other tissues. You can immediately see that there is a dark area like this. That is an ischemic stroke. Hemorrhagic stroke, here is one example. You see white color, hyperdense. This is hypodense compared to surrounding tissue. Okay, and if you decide this is a ischemic stroke, you need to get rid of the thrombus. If you decide it is a hemorrhagic stroke, you need to stop the bleeding. Okay, you give plasminogen, okay, platelet activating factors. Okay, management, I feel like I might do it in the beginning of the next class. It will take like 10 minutes. Right now, I don't want to do that because I need to check the recent guidelines. Okay, so if you guys have any doubts, you can ask me, and